We'll be talking on the primary prevention. Can I have the next slide, please? Yes. So moving ahead with the burden of cervical cancer, according to the GloboCan, that is Global Cancer Observatory data 2020, the worldwide, it is the fourth most common cancer in female, with new cases in 2020 being around 6 lakh and mortality from the cervical cancer around 3 lakh 40,000 women. For Indian women, it is the second most common cancer, with new cases in 2020 being around 1,23,000 and mortality from the cervical cancer ranging up to 80,000. So India accounts for 20% of the world burden of the disease. So as we can see in the world map, India has age standardized incidence rate of 18 per 100,000 women. So as we can see, this is a thematic map showing the representation of the number of deaths, mortality from the cervical cancer. And as we can see, India is being highlighted to have a large number of deaths compared to other countries. And as we can see, countries like Australia have become so disappeared from the map. So because they have already introduced cervical cancer HPV vaccination in their schedules. So based on the Indian data, in 2022, the projected incidence of cervical cancer was around 80,000 women, with the cumulative risk of developing cervical cancer being 1 in 75 women. And in 2025, the projected incidence is 85,000. So as we can see in the image, cervix of the uterus, the etiology is the HPV, that is the human papilloma virus. Harald Zurhausen received the Nobel Prize in Physiology and Medicine in 2008 as for his discovery of the persistent HPV infection being the necessary cause of cervical cancer. So after the HPV virus infects the epithelial cells, further it leads to infection and integration of the virus into the epithelium, which further converts this epithelium into precancerous lesions, that is CIN2 and 3, which causes further genomic instability leading to cervical cancer. Can I have the next slide, please? Yes, as we can see, not only cervical cancer, as ma'am said, there are various cancers which are associated with HPV. That is the cancer of the mouth, upper throat, vagina, vulva, anus, and penis. Most oncogenic high-risk HPV types are HPV 16 and 18, while there are other high-risk HPV types being 31, 33, 35, 39, 45, and so on. HPV is responsible for more than 90% of genital wart cases in male and men and women. It causes around 95% of the cases of cervical cancer. Around 30% of the cases of carcinoma vulva are associated with HPV. 70 to 80% of the vaginal cancers are associated with human papilloma virus, and 85 to 90% of the anal cancers are associated with HPV. So other diseases related to HPV are the genital warts, primarily caused by HPV 6 and 11 and leading to 90% of the genital warts. Anal cancer predominantly caused by HPV 16 and 18. Again, 90% of the anal cancers are HPV associated. Oropharyngeal cancers, that is HPV associated, are around 70%. We can see that around 90% of the recurrent respiratory papillomatosis is also associated with HPV 6 and 11. Bowen's disease has shown association with various HPV types like 16, 18, 31, 32, and so on. And penile cancer and precursor lesions are associated with HPV 16 and 18. And 35 to 40% of the penile cancers are caused by HPV. So as we can see from the graph, as women women after the 15 years of age, after they start their sexual activity, there is HPV infection, and following which, as we already discussed, by the integration of the DNA, it leads to pre-cancer. So as we can see, the pre-cancers peak after 30 years of age, and after the persistence and genomic instability, they further lead to cancer. So basically, we have this window from HPV infection to the start of cancer, and that's why, and we have two preventive measures. So in primary prevention, we have the HPV vaccination, And because of this margin of 10 to 15 years, women can undergo screening by secondary prevention. Can I have the next slide, please? So WHO, as you can see, the Director General, Dr. Tedros, announced a vision of WHO to cervical cancer elimination. And they have given coverage targets to scale up by 2030. The vision is a world free of cervical cancer with elimination elimination threshold being less than 4 cases of cervical cancer per 100,000 women years. And 2030 control targets are that 90% of the girls should be fully vaccinated with HPV vaccine by 15 years of age. 70% of the women should be screened with an HPV test at 35 and 45 years. And 90% of the women identified with cervical disease or a precancerous lesion should be treated. And as per the SDG 2030 goals, even they advise that there should be a 30% reduction in the mortality from the cervical cancer. So this is a 3-pillar strategy, that is vaccination, screening, and early treatment and palliative care integration. So I'll be basically discussing on the prevention. And WHO launched this program on 17th November 2020. So based on the impact modeling data, with this strategy of intensive vaccination and screening promoted by WHO, implementation of this strategy could prevent 60 million cervical cancer cases and 45 million deaths over the next 100 years. So after a natural infection with HPV, the median time to seroconversion is 8 to 12 months. And the immunological response varies from individual to individual based on the HPV type and the duration of infection. After a natural infection, most of the women will clear off the infection by their natural immunity. That is around 70 to 80% women will seroconvert. And antibody responses by natural infection are typically slow to develop and of low titer and avidity. While in men, we can see that the response is further less by the less response to natural HPV infection. And even the few men who seroconvert and antibodies are produced may not be protective. So the first HPV vaccination for the prevention of HPV-related disease was licensed in 2006. Till date, 125 countries have introduced HPV vaccine in their national immunization program for girls, and 47 countries have even included boys in the national immunization program. The vaccine is non-infectious because it does not contain live biological products or viral DNA. All the vaccines contain VLP, that is viral particles, for high-risk HPV 16 and 18. The quadrivalent vaccine contains 6 and 11 along with the 16 and 18, while the nonavalent vaccine contains high-risk VLPs for high-risk HPV types 31, 33, 45, 52, and 58. So as per the WHO position in 2022, they have recommended that the primary target population should be girls aged 19 to 14 years. And the secondary target should be females more than equal to 15 years of age, boys and older males. And the secondary target population is recommended only feasible and affordable. While immunocompromised women and men, including those with HIV infection, children and adolescents who have faced sexual abuse, should form a priority group in the public health program. So currently there are these 7 vaccines. The 6 vaccines which are licensed by the WHO. There are 2 Chinese vaccines, that is the Sicolin and the Volrenvax. Cervarix and Gardasil were the initial vaccines on which most of the studies have been carried out. And the last 3 vaccines, Gardasil, Cervavac, and Gardasil 9. These are the 3 vaccines which are available in India for vaccination for our women. And as we can see, Gardasil is a quadrivalent vaccine which is licensed for both boys and girls. And Cervavac is also a quadrivalent vaccine for 9 to 14 years of age women. It is recommended 2 doses 6 months apart, and for women, girls more than equal to 15 years of age, 3 doses are recommended in the schedule of 0, 2, and 6 months. Gardasil 9 is a non-valent vaccine, as discussed, and it also has similar dose number of doses. That is 2 doses for 9 to 14 years of age, and for more than 15 years, 3 doses. So Servavac, which is developed by the Serum Institute of India, it is the Indian vaccine which is now commercially available. It is a 2-dose vial is available, and it costs 2,000 per dose. So this cervical cancer is just the tip of the iceberg. With this HPV vaccination, we will protect the population from cervical precancers. Even cancers of the back of the throat, anal canal, vulva, penis, and vagina could be prevented by the HPV vaccination. And data shows that 2 doses of HPV vaccination provide similar efficacy and protection as equivalent to 3 doses when given before 15th birthday. So I'll now discuss the contraindications to the vaccines. So severe allergic reaction to a vaccine component or a prior dose of HPV vaccine is an absolute contraindication. The 9-valent HPV vaccine is contraindicated in women with a history of immediate hypersensitivity to yeast, and this vaccine is contraindicated in pregnancy. The side effects for the vaccination include local reactions at the site of injection. Fever may be present during the 15 days after vaccination. Systemic adverse reactions by the vaccination may be nausea, dizziness, myalgia, malaise. While some women may have side effects like syncope, and in extreme rare instances, anaphylaxis may be seen. So it is advisable whenever a woman comes for vaccination, the vaccine is given in supine position, preferably in the upper arm in the deltoid muscle. And girls should be observed carefully for 15 minutes after administration of the vaccine. We can delay the vaccination if the patient has moderate to severe acute illness, and the vaccination can be deferred until symptoms of the acute illness improvise. However, the vaccine can be given for minor acute illnesses like diarrhea or mild upper respiratory tract infection with or without fever. For missed dose, further doses can be continued as per schedule, even if more time has elapsed between the doses than is recommended. And if the vaccine used for the prior dose is unknown or unavailable, any HPV vaccine can be administered to complete the recommended schedule. So this is the data from the pre-licensure efficacy data. So these are the landmark trials by which Cervarix, Gardasil, and Gardasil 9 got their approval. So as we can see, the efficacy of the Cervarix ranges from around 85% to 95%, while the efficacy of Gardasil ranges from around 85 to 99%. So with the vaccination already, as we saw that 125 countries have it in the national immunization programs. So I'll discuss the real world data. Following 5 to 8 years of vaccination among girls 13 to 19 years of age, there was a significant decrease in the prevalence of HPV 16 and 18 and other HPV types, anogenital warts, and CIN2+ lesions. Australia started their HPV vaccination in the National Immunization Program since 2007, which was extended to young male population in 2013. So based on this data, we see that the prevalence decreased from 28 to 2.3% for women aged 18 to 24 years, and from 18 to 7% in men by the end of 2015. Even the incidence of high-grade cervical abnormalities decreased for women less than 20 years, and it became 5 per 1,000 women by 2014, which was less than half the rate in 2007. Similar results were found in Sweden, where the vaccination program started in 2006, and the incidence rate of the cervical cancer decreased by 88% in women vaccinated at less than 17 years of age, and by 53% in those vaccinated between 17 and 30 years of age. cumulative incidence rate came down to the elimination level, that is 4 per 100,000 women, by the age of 28 in the cohort vaccinated before 17 years. So the HPV vaccination showed around 83% decrease in the HPV 16 and 18 infections, around 70% decrease in the anogenital warts, and around 50% decrease in the cervical cancer lesions. As we can see, even in males, the oral infection decreased, with studies showing decrease ranging up to 100%. Anal infection also decreased around 25 to 35%. And genital infection also showed a decrease ranging from 30 to around 100%. As we can see that even pre-invasive lesions in males, for even pre-invasive lesions, the vaccine had a good efficacy ranging from 25 to 60%. So as per the WHO SAGE, that is the strategic advisory group, they have recommended that a single dose schedule provides comparable efficacy to 2 or 3 dose regime. Studies have shown that seropositivity among subjects who received 1 dose to be non-inferior to those with 2 or more doses. So in the position statement by WHO in 2022, they've said that even a single dose schedule can be used in girls and boys aged 9 to 20 years of age. As we can see that many countries have already adopted single dose vaccination in the national immunization program. That is Albania, Australia, Cabo Verde, Ireland, Solomon Islands, UK, Mexico, Tonga. These countries already have a single dose in their national immunization program. Indian Ministry of Health and Family Welfare has requested 7 states to start preparation for the rollout of HPV vaccination for girls 9 to 14 years of age. The first of the 3 phases, this is first of the 3 phases of India's HPV vaccine introduction. And HPV vaccination will become a part of the routine immunization program for these states after the children aged 9 to 14 years are covered. So these states are Maharashtra, Chhattisgarh, and Karnataka, where the government of India has recommended a 2-dose schedule for the national immunization program. While for the states of Uttarakhand, Himachal Pradesh, Tamil Nadu, and Mizoram, even a 1-dose permissible schedule can be used. So after this first set of states, other set of states and union territories will be further covered to 2025. And by the end, 68 million girls in India should have been vaccinated against HPV. And a further 11.2 million girls aged 9 years will subsequently be targeted for routine HPV vaccination. Based on the modeling study, assuming a 90% vaccination coverage rate in girls aged 10 years, this study showed that HPV vaccination could effectively reduce prevalence of HPV 16 and 18 infection by 97% in 50 years, with the incidence rate falling below the threshold for elimination. So since 2016, after the successful introduction of HPV vaccination in immunization programs in Punjab and Sikkim, as said by Director Ma'am, shows promise of future widespread implementation and evaluation of HPV vaccination. NTAGI, that is the National Technical Advisory Group on Immunization, had already recommended in June 2022 that HPV vaccination to be included in the Universal Immunization Program with a one-time catch-up for 9 to 14 year adolescent girls, followed by a routine introduction at 9 years. Now, with Cervavac being available, it is likely to be introduced soon in the Universal Immunization Program as a 2-dose regime for adolescent girls. So, as we can see from this graph, even with a single dose, we can reach like around in 50 years, India can reach the WHO elimination threshold, even with a single dose vaccination. So HPV vaccination, as discussed, helps in cancer prevention, is safe, and will further lead to decrease in not only cervical cancer, but other cervical pre-invasive lesions. And even further, when it is used for male, it will decrease in the precancerous anal and penile lesions. Thank you.